Bismillahirrahmanirrahim. Ladies and gentlemen, neonatal diabetes is a rare genetic condition which presents in first 6 months of life. Early genetic testing allows targeted treatment and may often replace insulin with oral sulfonylureas and ultimately reduces the long-term morbidity. Timely recognition of this condition enables personalized management and improves long-term outcomes. Today we are inviting Dr. Hussain Alsaffar. He is consultant pediatric endocrinologist at Sultan Qaboos University Hospital, Oman. He is member executive board at the Global Pediatric Endocrinology and Diabetes and is a research director at the Omani Diabetes Association. Welcome, Dr. Hussain Alsaffar.
Ladies and gentlemen, assalamu alaikum, good morning. Thank you very much for the organizers, first of all, for inviting me to be with you in the latest version of New Curriculum. And thank you very much for attending this session. Without further ado, I'm going to talk about neonatal diabetes, clinical challenges, and emerging therapeutic options. So the objective of this talk is to target the strategies and if there's any new treatment options in this field. I have no disclosures for this topic. And we know this neonatal diabetes mellitus represents a distinct genetic disorder. So far, over 30 genes have been discovered and identified. Alhamdulillah, so far it's a rare genetic disorder, but has got significant impact on the patient's lives, as well as their families' lives. It is distinct from type 1 diabetes because it is not related to autoimmunity here. It's related to the gene disorder that regulates the secretion of insulin from beta cells, or sometimes in the translation to form insulin. The model for personalized medicine, and we will shed the light on the molecular discoveries that has transformed the treatment for such cases. How do we classify neonatal diabetes mellitus? We do classify it into 3 subtypes. The first one is the transient one, the permanent one, and the syndromic diabetes mellitus. So the transient neonatal diabetes mellitus, the onset in the first weeks of life, usually they do have remission, may take up to a few months to settle down, but there is a higher recurrence risk, up to 86% of these cases later in life. What about the permanent neonatal diabetes? This is unfortunately a lifelong condition. And the common cause is related to potassium ATP channels, whether due to ABCC8 mutation or KCNJ11 mutation. And there are other genes could affect this permanent diabetes mellitus, as we're going to explore in the next few slides. And we have syndromic neonatal diabetes mellitus, where there are extra pancreatic features. Dent syndrome is one of them, for example, developmental delay, epilepsy, in addition to neonatal diabetes mellitus. The molecular diagnosis has largely superseded purely clinical classification. Previously, before the era of genetic testing, used to rely on the clinical manifestation to subdivide these types because you need them to counsel the patients and then to forecast the future of those babies. But there are challenges with this because there is overlapping and you cannot decide whether this is going to be a transient case or this is going to be a permanent case because they present exactly the same. But when you have genetic testing in hand, that will help you deciding on the management, will help you deciding on the counseling, the way that you're going to manage this patient later on. So worldwide, they say KCNJ11 and ABCC8, which is related to potassium ATP channels, are the most common cause of mutation, which is accounting for more than 50% of the permanent neonatal diabetes mellitus cases. What about chromosome 6q24 abnormalities? The abnormalities in this location has been attributed to the causes of transient neonatal diabetes mellitus. But it doesn't stop there. There are other genes that could cause syndromes or neonatal diabetes. Example of that, the INS gene mutation. So this is the potassium ATP channels. When we have high glucose, that will lead to increase the ATP. As a result of that, what happens is the potassium ATP channel will close. Once the channel closed, then the insulin will be released. That's the normal physiology. In a mutated potassium ATP channel, unfortunately, this channel is not going to close. It will remain open. Therefore, if you have high glucose, high ATP, that will not be accompanied by increasing insulin. There will be no insulin. For those patients who if you identify those patients with these genetic mutations that can affect these channels, if you give sulfonylurea, for example, that will help these channels to close and therefore will help in the insulin production. So in neonatal diabetes patients who you confirm their genetic testing, you will be easily shift them to sulfonylureas and then they stop the insulin. And there is a shifting in paradigm on management of neonatal diabetes mellitus after this discovery. Now, what about the incidence of neonatal diabetes mellitus? And we just mentioned the genes as well. So we said more than 50% of the genes are related to potassium ATP channel. Is that the case everywhere in the world? So if we look at the global data, so this is a publication from our friend and colleague, Prof. Asma Deeb. She looked into the incidence of neonatal diabetes mellitus in Abu Dhabi, and she compared the results with what is available in the literature. In literature, generally saying, the incidence of neonatal diabetes is 1 to 300,000 to 600,000 of population. But see what's happening in Abu Dhabi or in Saudi Arabia. About 50 per million. So that makes the incidence 1 every 20,000. So worldwide, they are talking about 1 every 300,000. But in Arab world, in the Middle East and North Africa, perhaps the incidence is much higher. And that could be attributed to the consanguinity. Do we know the figures for the incidence of neonatal diabetes mellitus in Pakistan? I don't think we got enough data to generate that figure. So this is an invitation for our lovely colleagues in Pakistan to look into this. What about the genes? So we mentioned the potassium ATP channels are the most common genes affecting the condition. And therefore, if we got them identified, perhaps sulfonylurea was going to change their life. Is that the same scenario in those cohorts of patients, in Arabs or in Asian? According to literature so far, well, what has been found in neonatal diabetes, at least from Saudi Arabia and UAE, the potassium ATP channel is not the most common type of genes that are affecting the conditions. It's related to other gene that's called Wolff-Rayleigh syndrome, Wolcott-Rayleigh syndrome, which is the E1F2 AK gene. Now, if we explore other challenges in terms of diagnosis, as we mentioned earlier, there is overlap of symptoms when the patient presents. Whether is it going to be transient, is it going to be permanent neonatal diabetes? So generally speaking, if any baby presents with hyperglycemia that is persistent for more than a week, and this baby is younger than 6 months of age, so this is going to be under the umbrella of neonatal diabetes as a diagnosis. And then from there, the international recommendation these days advising that genetic testing is a standard of care. It's mandatory because that will transform the patient's life afterwards based on the gene. So as a first challenge, if I don't have access to genetic testing, what am I going to say to the parents? Is this a condition that your baby is going to live with? or is this a condition going to settle in a few months? So that's a difficult question to answer. And that puts some dilemma here. And that's why I think we need to push forward that we need this kind of testing. It's very important. We need to prioritize, yes. We need to look at the cost, yes. But if we put ourselves in the patient's feet or the parents' feet, in the parents' shoes, then we'll find out the difficulty they may go through without knowing the future of their kid. Now, the critical importance of early genetic testing, we said it's going to be predicting the clinical course and guides treatment selection. And we said that identifying the sulfonylurea responsive mutations for timely transition to oral therapy. And this is very important next statement. The early treatment with sulfonylurea for patients with potassium ATP channel mutation is going to improve the neurological outcome of Dent syndrome, meaning less risk for developmental delay and less risk for developing epilepsy. And you could imagine, as all pediatricians sitting in this room, what that means to the patient and family, and even to the society. We would like to have a sound people around rather than people with learning difficulties or developmental delays. The cost of delayed diagnosis, there could be missed opportunities. So the first-line management, if you have patients with hyperglycemia, persistent hyperglycemia, whether it's transient or permanent, you need to put them on insulin. But if you don't have a definitive genetic testing to tell you exactly what is the problem, you may end up putting this patient on very long time on insulin, maybe years, which is unnecessary. Because if the patient is responsive to sulfonylurea, that very easy switch from subcutaneous insulin to oral therapy and save the family the whole hassle. How do you get access to insulin? How do you save it? When you travel, how to take it with you. So lots of hassle with having insulin. But if you can switch them to oral medication, that would be much easier. The clinical reality that transition is possible at any age, but sooner is better, as we said, for the outcomes. And it remains a global challenge for the limited access to rapid genetic analysis to define the condition. As I mentioned, more than 30 genes so far affecting the disease, affecting the patients and causing neonatal diabetes. So some of them, if we subgroup them into abnormal pancreatic development, so these are the genes that are responsible for abnormal pancreatic development, that could lead to neonatal diabetes mellitus permanent, plus pancreatic agenesis in most of them. Okay. There are other genes could be reflecting on association between symptoms. So if we have a patient with neonatal diabetes, plus hypergalactosemia, plus liver dysfunction, plus Fanconi-Bickel's syndrome, then we might think of SLC2A2 gene mutation. If we have a patient with thiamine-responsive megaloblastic anemia and deafness, in addition to diabetes mellitus, we might think about SLC19A2 mutation. If we have patients with intestinal malformation, heart anomalies, bone dysplasia, so we might think of KCNMA1 gene mutation. If we have patients with recurrent liver dysfunction and skeletal dysplasia, in addition to the diabetes mellitus, so we are thinking perhaps of Walcott-Rallison syndrome. What about patients with epileptic encephalopathy? So there is association with this gene, and so on. So there are genes that are responsible for multiple hits on the body on different systems, and the list is getting longer and longer. So just last 2 weeks, they discovered another gene contributing to neonatal diabetes mellitus. Management challenges. All of us know that when we got a young baby diagnosed with hyperglycemia and then alluding to neonatal diabetes mellitus, then you need to give them insulin. How are we precise to give small portions, small doses of insulin to those neonates? It requires very small doses. Therefore, often needs dilution, and there is always a risk of drug error in such patients. So it's not an easy, straightforward process. What about absorption issues? If the baby hasn't got much of subcutaneous fat and you're injecting subcutaneous insulin, then how much of that is going to be absorbed through the skin? How much of that is reaching the muscle, for example, and leading to increasing risk of hypoglycemia? Unpredictability. The pharmacokinetics are variable and risky in patients with neonatal diabetes mellitus. Feeding coordination. If we want to mimic the physiology, we ideally should give small portion of insulin with each carb intake. But how are we going to do this in a baby who's 2-hourly fed or 3-hourly fed? Are we going to inject every 3 hours? Practical questions, difficult answers. So talking about hypoglycemia as a risk as well. Hypoglycemia isn't a friend of brain development. We need to be very careful with hypoglycemia to ensure proper neurodevelopment, to protect the developing brain. Interestingly, in one of the studies where they looked into 975 patients who were KCNJ11 mutation patients who were on sulfonylurea, the severe hypoglycemia was very rare. And this is very good news. So not just a medication that is transforming the life of patient, but also reducing the risk of hypoglycemia and the risk of developmental delay. So careful dose titration remain a challenge, and it's essential during transition from insulin to sulfonylurea therapy, and other challenges matching insulin to variable milk intake, frequency of feeding, as I mentioned. Special consideration for premature infants. We know that they have minimal subcutaneous fat. We know they have immature organ systems. They could be insulin insensitive, and the requirement for close monitoring and specialized expertise are always essential. One of the challenges as well is how to monitor their glucose. Are we going to monitor their glucose by finger prick? With their prematurity, is that a healthy thing to do? Okay, what about using CGM, continuous glucose monitor, putting a sensor? In premature baby, that is a challenge. That's not an easy task to do. Depends on the gestational age and the weight of the baby. What about challenges in terms of neurological complication in neonatal diabetes mellitus? I think I mentioned that, but I would like to repeat it to emphasize the importance of this. There is a genetic link between neurological complications with some gene mutations, like in potassium ATP channels, because they are expressed in the brain tissue. So if we have a gene mutation there, therefore there is a risk of brain development issues. And they could be ranging from mild delay to severe dense syndrome. Therapeutic hope that sulfonylureas, as the evidence has shown, that patients on sulfonylurea will have less risk of developing DEND syndrome. And the care model requires multidisciplinary management. So in addition to neonatologists, we need endocrinologists and neurologists on board. What about challenges in the mode of giving the treatment? So we said insulin is the first-line therapy. That could be given as multiple daily injections, the traditional therapy using dilute, rapid-acting, and basal analogs. These days, the insulin pump is the gold standard to give fraction, small amount, micro-basal rates. It's a safe, physiological, and matching the metabolic needs of the babies. What about insulin analogs? There are variables, but such glargine, for example, has been used successfully and is effective even in extremely low birth weight neonates. The revolution that has brought by sulfonylurea, like glibenclamide, we mentioned that it closes the ATP channel, restoring insulin. Standard care, that's the glibenclamide, or also known as glyburide, is the primary agent, improving the glycemic control and reducing variability versus insulin, so less frequent hypoglycemia, less severe hypoglycemia, less negative outcomes. And it represents a major paradigm shift in neonatal diabetes management. The dosing is slightly higher dose that we give for patients with neonatal diabetes compared to patients with type 2 diabetes mellitus. we give starting between 0.5 to 2, reaching up to 2 milligram per kg per day, divided into 2 or 3 doses. And long-term safety, so far the studies have shown safe medication for more than 10 years on longitudinal studies. The severity of hypoglycemia is much rare on this mode of therapy, and monitoring dose adjustment guided by continuous glucose monitoring. Neurological benefit, I think this is the third time I'm referring to, and I hope everyone is getting the message. If we have patients proven to have genetic mutation affecting potassium ATP channel, where those genes are also expressed in the brain, so treating them with sulfonylurea is going to reduce the risks of neurological negative outcomes. What about emerging technologies? We mentioned about the insulin pump in general, but how about using a sensor-augmented pump or automated system where it's sensing the glucose, giving more insulin, or reducing the amount of insulin based on the reading that it gets directly from the continuous glucose monitor. I think the future is here if you want to give patients insulin subcutaneously, especially neonates. That's mimicking the physiology, therefore the outcomes is much better than giving patients just subcutaneous insulin, whether once a day or twice a day or boluses pre-feeds. This is my story with one of my patients. Presented with severe hyperglycemia found to be in severe DKA on day 3 of life. And the challenge is 3 days old. 3 days old. That's a big challenge for us. So started on titration, the doses, diluting insulin, given that the outcomes were not satisfactory at all. I knew from first day that we start managing this patient, the best option is to get insulin pump. In Oman, 2019, insulin pump was not funded by the National Health Service, but is not funded by the governmental hospital. And this patient in need of having insulin pump. So now the challenge came to us as a treating physician. How can I get this patient an insulin pump? The parents, they cannot afford it. It's very expensive. And they charge for the insulin pump in GCC countries much higher cost compared to Pakistan and India, despite the same brand. But this is the market. So now there is a message that I would like to pass here. As all of you, lovely physicians sitting in front of me this morning, all of us having extra duties towards patient, not just to follow whatever is available. So we need sometimes to go a step more. And then we start knocking the doors of people who do give zakat or charities. And you would imagine that one of the charities that we're not expecting a response from them at all. They have nothing to do with healthcare issues, another charity. But when we approached them and knocked on their doors and explained the condition, they agreed and they funded us to have insulin pump. And that was applied at age of 6 months for this baby. The management afterwards, since we have insulin pump, become much easier now. We don't need to dilute insulin. We don't need to be worried about the doses and how you give it, and then the skin and absorptions and all of that. So we managed to transform the life of this patient by just trying to have this kind of extra effort. And I'm sure you guys here, I'm not talking about using insulin pump in a country where the insulin itself is not provided by the system, the national healthcare system. But I'm sure as I could see the development every time that I come to Pakistan, and with the direct contact of my lovely colleagues, the pediatric endocrinologists, and amazing and tremendous work that they do, I'm sure that it's going to be one day as a standard care here in Pakistan. It's not far away from here. Thank you. Now, precision medicine in action. As we have seen here in neonatal diabetes mellitus, if you got to identify the gene, then you relate the genotype and phenotype, and then you treat. And so this model, success in neonatal diabetes mellitus, serves as a blueprint for other genetic conditions. And I'm sure that we have lots of examples in pediatrics. So long-term outcomes and monitoring, the lifelong follow-up is essential for optimal outcomes. Metabolic stability is very important. As we said, excellent control maintained for more than 10 years in sulfonylureas. Unfortunately, there is a risk of recurrence and puberty for those patients with transient neonatal diabetes. And sometimes patients who are on sulfonylureas, but there is a failure of treatment that we need to be aware of later on during the adulthood life. So they need to be restarted on insulin afterwards. And if you have proper management throughout the pediatrics, that will lead to seamless transition to the adult care. Now let's take in the next 5 minutes case vignettes from Pakistan about neonatal diabetes mellitus. So real-world clinical patterns and outcomes in neonatal diabetes mellitus from this country. The source is synthesis of peer-reviewed reports, conference abstracts, and the scope covers the potassium ATP channels mutations as well as other gene mutation leading to the diabetes. Significance, it illustrates genetic diversity and management challenges in diverse population, and it highlights the critical role of genetic testing in guiding therapy. First one from my colleague Muzna Arif. So she published a case series about potassium ATP mutation, success stories, successful transition from insulin to sulfonylurea in 5 infants. So she had a cohort of 5 patients with neonatal diabetes found to have confirmed the KCNJ11 and ABCC8 mutations, transitioned from insulin to oral sulfonylurea, and that was reported as a success story. Changed life of patients. 4 of her patients presented with severe DKA in first month of life. 1 presented with failure to thrive at 6 months, but all of them, when they switched to sulfonylurea, managed very well. The other one from Fozia Memoun, case series about Walcott-Rallison syndrome, this extreme rare syndrome leading to diabetes mellitus, as well as skeletal dysplasia, hypothyroidism. So 3 patients from consanguineous families, presented with hyperglycemia, diabetes in infancy, they require insulin. Genetics showed and confirmed the gene that is causing this. And outcomes, unfortunately, high mortality. 2 of her patients died from liver failure and complications, 1 survivor at 2 years follow-up. And Walcott-Rallison syndrome is the most common cause of neonatal diabetes in countries where consanguineous marriages are common. So perhaps there are much more cases than we just read from literature. I think we just see the tip of iceberg. A case report from Sabine Abid Khan, a 9-month-old infant girl presented with severe neonatal diabetes spectrum, developmental delay, epilepsy, so basically everything fulfilling the criteria for Dent syndrome, found to have KCNJ mutation. Management highlighted that oral sulfonylurea as therapeutic option is in such mutations. So key lessons from Pakistani cases and the implication for neonatal diabetes management in resource-limited settings, the genetic diversity of the cases. So we mentioned that they got Walcott-Rallison syndrome, and we have the potassium ATP channels, and perhaps the other genes as well. And what we've learned as well, the actionable diagnosis, genetic testing directly guided successful theory changes, and reporting gaps, needs for more detailed longitudinal outcome data in case reports, and clinical reality here, the high morbidity in patients with Walcott-Rallison syndrome. Unfortunately, 2 of her patients died at quite early age. Those patients could have been saved for longer if they were treated intensively. Future directions, I think we need to work more on access and improving the genetic testing availability globally. And I'm sure Dr. Sumaya Aftab is working tremendously on this with Exeter, for example, where people are sending genetics there. Failure in, researching mechanisms of sulfonylurea treatment failure. So there's an area that needs to be explored further in the future. Neurology, about neurological benefit. Globally, registries definitely needed. Perhaps as a suggestion, we need to start with local Pakistani registry to start with. And there is an invitation here for my colleagues. This is a quick literature review about cases from Pakistan, and I found those cases. But if you work collaboratively, and I'm sure we have now pediatric endocrinologists representing all the governorates or cities, big cities in Pakistan, then why don't we join all of these, either from literature review and coming up with one paper summarizing all of that. And as an editor of one or two journals, I will promise that if we got this paper, then I will help with facilitating its publication, either in the Turkish Journal of Clinical Research in Pediatric Endocrinology or in the Gulf Journal, the JDP. So that's an invitation for you guys to work on formalizing local data of Pakistan about neonatal diabetes mellitus. Now, the executive summary of what I talked, the incidence of the disease worldwide is 1 to 300,000, but I showed evidence that in adjusting nearby countries like in Saudi Arabia or UAE, the incidence is 1 to 20,000. So I don't know exactly what's in Pakistan, but I expected that is high incidence of the disease because of the consanguinity. Genetic testing now identify causes in 80% of the cases. Paradigm shift in the management and challenges were early diagnosis, premature infants, hypoglycemia, neurodevelopmental outcomes. And as a token of appreciation to my colleagues in Pakistan, we are working now, and Sumaya as well, one of my major collaborator, on randomized controlled trial, where we are studying the tool that we have developed it using AI, pediatric insulin calculator, where it helps patients to adjust their insulin doses, gives corrections, and if the patient's using continuous glucose monitoring, then will advise accordingly, the carbs and all of that will just give the patient a small and easy advice on the dose. And we made this tool available in a number of languages, in Arabic, French, Spanish, Urdu, and Russian. So I hope what we have decided as steering group of this randomized controlled trial to let Pakistan start the first country recruiting for this study, as we got 42 principal investigators worldwide working with us on this randomized controlled trial. But as a token of appreciation, me and Prof. Nandu Thalanj, his name is there, where we are leading on this clinical trial, decided to let Pakistan take in the opportunity to start recruiting first. And another promise, we developed another tool using AI for pediatric DKA management. Again, that will help to reduce and minimizing the errors that could happen, especially in emergency rooms. Since yesterday, I learned from my colleagues in Child University Hospital, 2 consultants covering very busy service, like they have 800 newly diagnosed patients with type 1 diabetes mellitus annually. I haven't seen this figure anywhere on my travels or talking to my colleagues. Big workload. So I said, okay, decided last night that's my present or token of appreciation to my colleagues in Lahore, will be providing this calculator freely and make it available for them. And by this, I will stop here, and thank you very much for listening.
Thank you very much, Dr. Hussain, for this in-depth overview of neonatal diabetes mellitus, especially the calculators.